and welcome to the Museum of Science. Feel free, you can speak back, that's great. My name is Sylvie Rosenkalt. I use the pronouns she and her, and I'm the accessibility coordinator here at the museum. This month, we're joining a national conversation on disability and reproductive equity. Here at the museum, our programmatic theme this year is being human. And what could be more human than the experience of disability and its deep connection to our right to have a child, to not have a child, and to parent in a safe and supportive world. So to help open this space, we're honored to introduce a national leader who champions equity and bodily autonomy with a video message from our Congressperson, Ayanna Pressley.
Good evening, everyone, and happy Disability and Reproductive Equity Day. I wish that I was in community with you all to mark this important day, but I have a long-standing conflict, but it was important to me to offer a few words, albeit virtually. First, let me just start by thanking the Museum of Science for hosting and inviting me to share a few words before you hear from these incredible policymakers, table shakers, and change makers. I'll be brief. But let me just reiterate that as a lawmaker, I seek to advance policies that are intersectional because we live intersectional lives. And disability justice and reproductive justice have been at the heart of my work, dating back to my days on the Boston City Council and certainly now in Congress, where I seek to bring a lens of disability justice to every single issue, because every issue is a disability issue. And I co-chair the Reproductive Freedom Caucus, so certainly bringing that lens in every facet of my work as well. Tonight acknowledges the anniversary of the infamous Buck versus Bell Supreme Court case, a stark reminder of the imperfection of our criminal legal system and the power of social justice movements to address legislated policy violence. As I've said many times before in studying movements, what history has shown us is that government doesn't always lead, but it does respond. It is shameful that this decision has never been formally overturned, but due to the organizing, mobilizing, and demand, really accountability from leaders in this room and the ones whose shoulders we all stand on, we have passed federal and state legislation like the ADA to address some of the hurt and the harm. But make no mistake, as was the case with the Voting Rights Act and the Civil Rights Act, Congress did not pass this legislation out of a sense of benevolence. This had everything to do with legislators responding to demands from the people, from a movement that refused to accept an unjust status quo. And those demands, the policy fixes we know will provide the foundation for health, wealth, and safety for every person that calls this country home, are strongest and most sustainable when they are crafted with those most impacted at the table. Something I call cooperative governing, the people closest to the pain, being closest to the power, driving and informing the policy making. Now, when I was first running for the Boston City Council in 2009, I ran on a platform saying that I wanted to save women and girls. I wanted to champion gender-specific and responsive programming and policies. And many people tried to dissuade me from that pursuit, saying that that was not the work of municipal government, and maybe I should go run a nonprofit instead. But I knew better. And the city of Boston affirmed by electing me in 2009 that they did want someone to champion the unique and specific needs of girls and women and champion gender-specific and responsive programming and policies. And so the power of that was made evident during our first budget cycle. Every question that I asked of a department or agency, when I would say, what about the girls? Their answers were monosyllabic. But by the second budget cycle, the next round, they came with binders that were cross-tabbed and multicolored because they knew that someone would call the question. And that is truly the power of a more representative government. That is the power of representation and unique lived experiences informing policy. And you are all a testament to our collective power to make change, regardless of who sits in the Oval Office. We can and we will overcome together. So just know that this Congresswoman is in solidarity with you this evening, demanding equity and access to healthcare and every day thereafter. And I'm so grateful to you for raising your voices, for sharing your strength, your wisdom, your gifts with this movement, and for the chance to address you just for a couple of minutes tonight. And I can't wait to see you all in community real soon. Thank you again.
As we move into the panel, we invite you to participate in the conversation in a couple of ways. You could visit slido.com and enter the code EQUITY to submit questions for our Q&A, and the instructions are behind you. We also are collecting a survey tonight about this event and other events that go on at the museum. So if you'd like to add your voice in that way, we'd love to receive your survey. We have both a QR code and paper copies of the survey over there with my friend Julia. All right, so now I am thrilled to introduce our incredible panelists. Dr. Monika Mitra is the Nancy Lurie Marks Professor of Disability Policy and Director of the Lurie Institute for Disability Policy at Brandeis University. Her research centers on the intersection of disability, health, and reproductive justice. She is nationally recognized for her work on the reproductive and maternal health care needs of people with disabilities. Dr. Tiffany Panko is an associate research professor and the executive director of the Deaf Healthcare and Biomedical Science Hub, or DEF Hub, at the Rochester Institute of Technology. As a women's health researcher and passionate about reproductive justice, her work focuses on investigating healthcare access, health literacy, pregnancy experiences, and family planning in the deaf community. Mia Ives-Rublee is a disabled transracial adoptee who has dedicated her life's work to civil rights activism. She obtained her master's in social work at UNC Chapel Hill and began working with disabled people to help them find work and independence in their communities at the North Carolina Division of Vocational Rehabilitation Services. Mia is best known for founding the Women's March Disability Caucus and organizing the original Women's March on Washington in 2017. As a public speaker, Mia advocates on the national stage for the rights of disabled people, immigrants, and other marginalized communities. Please join me in welcoming our panel.
Hello, everyone. Good evening. As Sylvie said, I just want to make sure I can be heard. I'm Monika Mitra. I direct the Lurie Institute for Disability Policy, and I'm a professor at Brandeis University. And I am absolutely delighted and honored to moderate this panel today and to share the stage with Tiffany Panko and Mia Ives-Rublee. Before I begin, I want to thank all of you for coming, and I also want to thank the Museum of Science for pretty much providing the coolest space possible for the talk today. And Sylvie for organizing and bringing us together. I also want to thank Representative Presley because she has set the stage, but also been a tireless advocate for disability justice and reproductive justice. So today's conversation on reproductive justice and disability justice is both urgent and long overdue. Often the conversations around reproductive equity, reproductive justice do not involve people with disabilities. And often disabled people are not at the table, and often they're not welcome to the table. And what we're going to hear today, and we're going to, what the message is, we need to center disability, center the lives of people with disability, center the disability community as we, in every conversation on reproductive equity. Reproductive equity is not possible if disabled people are not part of it. And this is especially, between systemic ableism, between the, really the pejorative attitudes towards disabled people, as well as the current really challenging policy environment where disabled people's right to health care, education, social supports, and the state control of reproductive rights. All of this is in the middle of all of this, I think this is even more pressing to have this conversation. And so here we are today with Mia and Tiffany, and we're going to spend about 45 minutes conversing, and then we're going to open up the floor to all of you here, both in person and online, for a Q&A, a brief Q&A session. So Mia, I want to start with you. Can you tell us a little bit about the journey, your journey into disability policy, but particularly at the intersection of disability policy and reproductive rights?
So I think my dog actually wants to get involved in this conversation as well. So I grew up in a family where it was very obvious that I had a disability. My parents were pretty good at being able to talk about disability and talk about sort of my rights and needs, but it often really focused on either my health or my journey towards becoming independent. And the conversation around sort of relationships and sexual education and sort of these other things seemed sort of tangential to a lot of the way that I was growing up and figuring out the world. And so, I think that it took a while for me to really understand that I was seen differently and that people made assumptions about not only my sexuality, but like whether I would be able to parent, whether I could live independently. And those things started coming up as I got into high school. And so, I got into disability work as a social worker and began thinking about how I always felt like I had to portion out myself, where I was either disabled or as a woman or as an Asian American. I could never really talk about these things tied together. And so I remember sitting in social work classes and being like, I don't see myself in this work. I don't see my experiences reflected in this work. And so that was when I started really doing my own research, which I know nowadays that kind of sounds like pejorative, like just due to the misinformation that's abound now in social media. But back then, it was really about trying to find myself in the work, trying to find disabled women who showed up, were advocating for a wide variety of issues, including women's rights issues. And so, ran into Fannie Lou Hamer. Her work was, foundational to a lot of the work that I do today. Judy Heumann. There were just a lot of different people that I got to learn from, but that had to be sort of like extracurricular. And so the work that I've been doing for a while now is to try to ensure that people do see themselves in advocacy. They're able to recognize their whole selves in the work that we do. And I think that's really important to be able to feel like you're included and that you're being seen and that your issues are going to be addressed.
Thanks, Mia. Tiffany, I'd love to hear about your journey as well into this space.
Sure. So I really started my sort of professional journey, I would say. I liked how Mia said that, actually. I'm a deaf person, so I was looking for representation in the same way. The actual impact of where I ended up started at the beginning. When I was in college, I was always involved in public health research. That was always an interest of mine, thinking about research around the deaf population. But where I didn't have an end goal in mind at the time. The field was appealing to me. And when I was in college, you know, you think about medical school, you have rotations in medical school, and I always tell people that the reason that I got interested in women's health in particular, particularly women's health, it sort of chose me, I would say, as opposed to my choosing it. Working with patients and feeling like I could empower patients through information that I could share, seeing the experiences that they'd had, the struggles, the challenges, and even going to the OBGYN as a deaf person, as a deaf woman, and feeling like so unsure of yourself. And I saw that there was a way I could encourage patients to advocate for themselves, to receive that empathy in those spaces that they deserve. So I thought about medical school, but I really discovered that research was really more my field, and I did 2 postdocs. I knew I wanted to concentrate in women's health, but that's a huge field, so how do I specialize? I took some time to do some research and figure out exactly which part of the women's health sort of universe was appealing to me, and I worked with contraception, as well as pregnancy experiences and abortion experiences as well. So those are the 3 focuses that I work with right now, family planning, and my interest in advocacy around those areas. At the moment, I'm still involved in research, but a little bit less because we're focusing a little bit more in the work that we do in change and implementation. So I am the executive director of Deaf Hub right now, as was mentioned in my bio, and we're trying to encourage more deaf and hard of hearing people to become doctors, to join the healthcare field as providers, to be biomedical researchers, whatever their interest may be in the field. So because that way, the more representation is there when deaf patients go to see their doctor is also deaf, also uses American Sign Language. So that would be where I'm at right now.
Thanks, Tiffany. You know, sort of both of you brought up, and Mia, particularly what you said about sort of not seeing yourself, right, growing up. And a lot of that relates to sort of this dominant narrative that disabled people are unfit to be parents, they're non-sexual, they should not be pregnant. And so what I'd like to hear from both of you, and you know, Tiffany, maybe starting with you, is how do you think this dominant narrative affects clinical care, particularly clinical care for deaf people, but also just in terms of clinical care in the reproductive space, of course, for disabled people?
Sure. So I would say there are 2 main areas that I would address with that. The first one would be a lack of data around deaf people, and then a lack of information, or really, I guess, a lack of information access, or inconsistent information access. People would think that this doesn't necessarily apply to you as a deaf person or as a deaf person who might become pregnant, and then a lack of access to that information. The lack of data I can speak to, we always think about women's health, right? So generally, not particular to deaf people, but women's health generally, is the data in that field was actually really sparse. We saw it in the 1990s start to increase because there were now female researchers on the teams, in the labs, leading the labs. And so the research that had that representation was therefore more meaningful. So what we need to do is more research. In the 1990s, deaf women, that came later, the deaf researchers came later to the field as well, but in 2020 there was an article that was published that said, we know that deaf women are on par with their hearing peers as likely to become pregnant to the same percentages, but 67% of those women are more likely to experience unintended pregnancies. And that was 2020. We're not talking about a long time ago. That's a very important statistic. In terms of lack of information, I would say it's important to consider that deaf people generally experience a limited or a less vibrant fund of knowledge around health literacy. So health literacy meaning, of course, the ability to find information, navigate that information, understand, comprehend that information, and then apply it to their own lived experience in order to make their healthcare decisions on their own. And so that's a very basic human need. So deaf people are almost 7 times more likely to have inadequate health literacy compared to their hearing peers. And that has been documented as well. I may need to check my notes, actually. Hold on one second. There was one other thing I wanted to mention here. So those are some of the important considerations. And then once a deaf person gets into the doctor's office, they're meeting with their provider, is there an interpreter, right? Maybe, maybe not. Does the provider themselves know how to work with a deaf person? Have they had a deaf patient before? Can they understand the deaf culture? Can they even consider that there is a deaf culture when a deaf patient comes into the room with them with limited or insufficient health literacy information? So there's a lot of considerations, even just accessing their provider. At this point, I think it's also important to talk about the importance of reproductive justice and what that would mean to me, for example, as my lived experience as a deaf woman. I think I want to repeat the definition of reproductive justice. I know it was mentioned at the beginning, but that is the human right to personal bodily autonomy, and the right to have children or decide to not have children, and then the ability to parent them in a safe environment. And so at the moment, I've worked on 3 of those 4 pieces. And I'd like to break down the first one, if I may, that personal bodily autonomy. What do we mean by that? We mean getting information, complete information, having access to that, whether or not whether the information is available in ASL. I can say also there are 2 that I know of, 2 organizations that I know of. One is called Who Not When, that speak about speak about late abortion in American Sign Language. They recently added ASL materials, I would say maybe 2020, 2021, not that long ago again, but now their materials are available in ASL also, and so expectant parents or folks who are considering abortion have that opportunity. And then there was a second one, so that when folks go to the doctor, they're getting that full information about the options that exist for them in whatever situation they may be, and maybe that's abortion and maybe it isn't. So the reason that I'm here is to talk about disability reproductive justice, right? And the reason that it's important is that when we look at reproductive justice from a disability lens, of course that brings the picture into focus, but there's a lot of benefit to justice for all of us. So in particular, contraceptive research, one finding that is pretty common from deaf people to their hearing peers is that there are some barriers that we can expect, right? Maybe there's not enough sex education. We know that right now we find that hearing and deaf people in schools are experiencing insufficient sex education. Maybe we need things as deaf people, maybe hearing people need them as well to be more visual than they currently are. Maybe the materials that are provided in education are not as complete as they could be. And I think they're also not created in a way that considers the potential audience. I could probably stop here because I could go on for a while, but that's my answer.
Thank you, Tiffany. So Mia, Tiffany spoke about how this dominant narrative, this is what happens when I get excited. So Tiffany spoke about how this dominant narrative is affecting clinical care for deaf people. I'm wondering if you can sort of expand on this dominant narrative of disabled people being unable to parent, really shapes public policy.
Yeah. I can go all the way back to the eugenics movement to explain why there was such a push to not include disability within sex ed, to not believe that disabled people should procreate or to parent. So we're coming from a culture that already sort of delegitimizes disabled people, does not see them as human, does not allow them to make not only their reproductive choices, but their health choices either, right? So we have these individuals who are often institutionalized. If not institutionalized, a lot of times they are talked down to, they're paternalized, and so these individuals are often not in control of their lives in general. We see guardianships happen all the time where we see kids going straight from IEPs to guardianships without any real conversation about trying to help them become independent, sufficient people in communities. And so these individuals are often trained by the people that they trust to believe that they have no control over their bodies. And so when I look at the disability rights movement, and I look at the reproductive rights movement, there is a lot of overlap because there's this belief that certain individuals do not have a right over their own bodies, to control their own destinies, to control their own bodies. And so we see a huge amount of, I believe it's up to 90% of individuals with intellectual disabilities who are victims of rape and sexual assault. For disabled women in wheelchairs, the rate is around 60 to 70%. And so it's higher amongst individuals with disabilities than it is amongst individuals without disabilities. And part of that is because, one, they have more difficulty complaining about the situation. And when they do complain, they're often not believed. So we have this situation where individuals are at risk of being sexually abused and thus at risk of becoming pregnant. And then when they do become pregnant, often they're told they're not allowed to raise their own children. Disability can be a main factor for removing a child from a home right now in many states. And so then we have sort of this cascading effect where these individuals are treated as subhuman, and we have a continuation of that through even the reproductive rights movement, where a lot of individuals say, you know, we have abortion because we need to abort these children that have disabilities. And so we've had this difficulty of bridging the gap between the disability rights movement and the reproductive rights movement, even though we're fighting for the same things, because there's this misunderstanding of the disability community and what they're fighting for, and partially that's because we're not allowed to speak for ourselves, right? And so when we talk about the need for representation, not only in the medical field, but the research field, but also the advocacy field, to be able to speak for our own selves and talk about our wants, our needs, and be able to make decisions for ourselves, that's what's so essential within the rights and justice movement, is the belief that we have control over our own destinies, we have control over our own bodies, and that this is the key factor that will bridge these two communities together.
Thanks, Mia, and that's really powerful that disabled people are not allowed to speak for themselves, right? Like that, those words, particularly in this space. Both of you kind of talked a little bit about sort of some of the barriers that disabled people face in getting reproductive care. And it begins early on. It begins very early on, even before sex ed. And Mia, you raised this really important issue that's often not discussed in spaces, is also the really high rates of violence, sexual violence, and emotional violence, and all different types of violence that disabled people face. Can you both sort of expand on barriers that disabled people face in accessing care, and particularly disabled people who are from multiply marginalized populations? And I would really appreciate if you can speak about the, and I know, Mia, you touched on this, is medical bias and gatekeeping that often happens in clinical spaces. Maybe Mia, you can start it off?
Yeah, I think in categories, in 3 different categories, when thinking about sort of the barriers. One is just general financial barriers. So a lot of disabled people have less means. Partially that's because there's discrimination around being able to work. Individuals get paid sub-minimum wages. Individuals who receive SSI or SSDI, well, mostly SSI, are on asset limits. People who are on Medicaid are on asset limits as well, which means you can't earn a specific amount, you can't own a certain amount, you can't save a certain amount, right? So we have this financial barrier of being able to receive care. Then we have an accessibility issue. Whether we are talking about sex ed, is that accessible to individuals with disabilities, whether it is a language barrier, whether it is a reading or medium barrier, whether it's a cultural barrier, right? When we're talking about multi-marginalized communities who maybe don't speak English, or who are from migrant communities, immigrant communities, to things like devices, diagnostic equipment being accessible. One of the things that I've been working on for the past 3 to 4 years, looking at diagnostic equipment and how it's not accessible for many individuals. So we're looking sort of at that area. And then lastly is just an access to information. A lot of disabled people are not given this information because they are deemed as not important to their their ability to live, basically, because so much is focused on sort of surviving a disability that there isn't a focus of how do we ensure this person is a holistic human being, right? And so I know, like, when I go to the doctor, when I go to the family doctor, half the time I'm not asked if I have received reproductive health care. And a lot of individuals with disabilities say the same thing. They're not asked these questions. They're not asked when their last menstrual cycle was. They're not asked if they have been doing breast exams. They're not asked a lot of different questions. And so what's happening is that these individuals are actually being found to have reproductive cancers at much later rates. So they're at the final stages of cancer and thus are much more likely to die of reproductive cancers than other types of cancers because they're not receiving screenings. So, you know, access to information, access to the general diagnostics, and then financial ability to pay for it.
And also in our research, often doctors are recommending, you know, sterilization, for example, for young people with disabilities, with consent of family members. Tiffany, I'm wondering if if you can share sort of your experiences and how this plays out in the deaf community, particularly in terms of clinical care.
Sure. Barriers, I would say there were 3 that I would mention. First of all, where do you find a provider? That's the first question. One thing that is unique about the deaf and hard of hearing population is that they use the emergency department more often for their medical care than going to their PCP. There are a few reasons for that. One giant reason is that the emergency department is accessible. It's always open. You don't need to wait for an appointment. It can be difficult to find a PCP that you find rapport with. And if you can't find one you find rapport with, then it might be easy to use the emergency department as a gap filler. And that leads to the second one, which would be inconsistent access to information, because maybe there isn't an interpreter, maybe there's a refusal to provide interpreters, maybe there's an interpreter provided who isn't qualified. So information is certainly a central piece of the access to medical care. And it may be also that once you have the information from the medical provider, you're able to look it up at home. I'm a researcher, so there's some quotes that I wanted to be able to provide. So I'm sorry I'm looking at my notes, but they will be worth it, I promise. So the extra layer of this for deaf people is that interpreters, we've discovered, can be either a barrier or an asset. People who've had pregnancy experiences sometimes report very positive things and can say, for example, that they know that having the interpreter there made me more comfortable, that interpreter held my hand during labor, and that was very helpful for me, it was very comforting for me. But I also did a recent interview about abortion, and there's no comparable quotes that I can give you about that. It's not necessarily that it's a barrier in that case, but the interpreter is not providing a comforting presence. The interpreter is being maybe extra professional, and in that way, lower affect means that the deaf person experiencing the medical care feels like, they may not even want an interpreter there because it doesn't make them feel more comfortable. It doesn't make them feel like they're getting more information. Do I want an extra person in the room when this is a very intimate appointment and I'm feeling very vulnerable already? That becomes a communication challenge. In terms of medical bias and gatekeeping, I would love to share some more of these quotes from you from folks who've gone through abortion experiences. They make the point much better than I can, and so I will read a couple of them to you now. In terms of the relationship with their doctor, they said they did not get full information. There's two quotes I'll read. One said, "They discussed and decided what was best. I was disappointed that this dragged on longer." And the second one is, "Providers didn't really interact with me because my parents were hearing and they were conversing with the doctors and nurses. I was not able to catch anything that was going on. I felt like a kid, even though I was 19 years old at the time. I should be old enough to be involved in this conversation." So I find those two quotes really poignant. And then another quote about inconsistent communication access. The doctor wrote down on the paper saying, quote, if you're sick and have an abortion, then you'll be fine." And I was like, okay, that's it. The doctor never really explained to me what actually happened. So even in our most recent conversation, this person didn't understand to that day why she needed an abortion, why that was even an option. So these are just some examples from my own personal qualitative research about what's going on out there in the world even today.
Thanks, Tiffany. It's sort of segued into my next question, because we cannot talk about reproductive justice, we cannot talk about reproductive equity without talking about the Dobbs decision. So I really want to hear from both Mia and Tiffany. How do you think the Dobbs decision has impacted disabled people? And really, kind of what should be watching for next? And it would be great to also hear sort of from your own perspective. And I know, Mia, you've been working in this space through your, through CAP, is, what are we doing in the policy environment related to this? Tiffany, do you want to start?
Oh, sure, yeah. I would say the biggest issue is confusion around the Dobbs decision in the deaf community. I had a friend who actually asked me shortly after the decision was handed down, she said, so that means abortion's illegal in the country now, right? And I said, no, but it means that it's state-by-state decision, and that's actually more confusing. The laws that exist or that may need to be changed that impact our daily lives have sent this wave of confusion through the deaf community, who are already at a disadvantage navigating these complicated medical systems. And as I just mentioned, the interviews that I've been doing around abortion experiences, even before Dobbs was handed down, in multiple years, there were challenges with where to go for abortion care, weighing whether it made more sense to go someplace local because it was local and accessible, or to focus on communication access. And so I think the confusion that has been is even worse now.
It's just so important to hear, because we as a researcher, I'm well aware of the disparities in health literacy between deaf people and others. But then you look at the Dobbs decision and you realize, like, this is such a concrete example of health literacy, right? Is this confusion about what this means, and how does it affect them? So, yeah.
Yeah, I mean, even doctors don't really know what the rules are. Some places have specific exemptions for specific medical conditions, but they're not sure, does the person have to be literally on their deathbed, or are they likely to be on their deathbed? So there's a lot of confusion out there, definitely. And when you're already having a lot of confusion, adding this nuanced conversation into this really very contentious issue that can be very traumatic for families to make a decision on. We're looking at recipes of disaster where we have literally a woman, I believe in Florida, who was considered brain dead, but is being kept alive because her fetus is still viable. And so, I mean, I can't imagine what the family is going through right now. One of the things that I think about a lot when politicians go out there and they're like, well, states can decide and people can travel and yada, yada, yada. Traveling is extremely hard on any circumstance. But when you talk about individuals with disabilities, we talk about an added weight to the conversation, because a lot of individuals with disabilities can't travel. They don't have a vehicle to go travel. They might not be able to get on an airplane to go travel. And we're talking about some places they have to travel 1 state, 2 states to be able to find a location that will take them. Because when you add disability, a lot of these places get really, really nervous about interacting with disabled people because they see it as an extra complication. So you might chat with a clinic and you're saying like, oh yeah, like I need this procedure done. Oh, by the way, I also utilize a wheelchair. You can sometimes hear a pin drop when they hear that. They're like, oh, wait a minute. You need to do this at a hospital setting. You need to do this at a specific place that understands your condition and the types of symptoms that you could have if this goes wrong, et cetera, et cetera. And so we're looking at like not only reducing the clinics that are available in the state, but you're also reducing the chances that you'll find a place that can handle and manage your condition along with the procedure. So we're looking at that. Plus, we're looking at the financial burden that everybody is dealing with, but is so much more difficult when you have a disability, whether you have to pay for a personal assistant to come with you on that trip. What if your personal assistant does not approve of you having that, so you can't actually get them to travel with you? I mean, all of these issues are compounding for disabled people, so it's not just simply saying, oh yeah, I can go to the next state and get this procedure. And I think it's really important to understand that for disabled people, there are times when having an abortion will save your life, because you cannot have a baby without putting your life into danger. And so I just get so annoyed when I hear these politicians who go out there who have no idea what they're talking about and are really just talking out the side of their mouth because they don't understand the situations that people go through on a daily being.
And that relates to exactly this conversation that disability needs to be front and center if you're having a conversation on reproductive equity. And I think added to your, all these barriers is also just accessible environments. Is the transportation system accessible? Is wherever this, this other facility that they're going to, is it accessible? And just also the attitudes, how are people interacting, and what are their attitudes towards providing care to disabled people? So I know we covered the Dobbs decision, and speaking of really complicated, challenging policy environments, the current environment where we're seeing attack on Medicaid, attack on disabled people's ability to live in the community. So we're possibly looking at a future, and not too distant future, that disabled people, more and more disabled people will be institutionalized. We're looking at dismantling of social supports. We're looking at sort of reduced access to quality education. And I'm not even sure when we talk about Social Security, again, there's additional threats. And then we add to that the state control of reproductive autonomy. We know that the disability community is uniquely impacted, disproportionately impacted, and as you said, Mia, it's the impact is compounding. What policy changes are urgently needed to advance reproductive equity for disabled people?
Oh, yeah. So there's a couple of them. I think one of them I worked on with a coalition. The Center for American Progress helped actually establish sort of a conversation and a group of organizations that began talking about how disability is impacted by reproductive rights and how and vice versa. And we understood that one of the big areas is inaccessibility at clinics. And so one of the areas that we worked on was to update the Rehab 504 Act for HHS. Rehab Act basically says that any place that receives federal funding has to be accessible for disabled people, and under HHS, that would mean any place that receives Medicaid, Medicare, or any federal dollar grants in particular. And so what we helped do was update it so that there were clinical standards and requirements for specific diagnostic equipment so that individuals could receive reproductive health care, general health care as well, but particularly reproductive health care, and also to reduce the stigma around disabled parents having children, and stating that individuals should not be discriminated based on having a disability. Unfortunately, right now, because Texas is going to be Texas, they decided to do a lawsuit against the 504 regulations, which means that unfortunately the progress that we did make is under threat right now due to, I believe, 6 or 7 states that are now suing the federal government for these changes. So we need more accessible clinics. We need to decrease some of the stigma around disabled parenting. So that's one area. I think the other area is increasing healthcare access. That's a huge area, but in particular for disabled people. I think a lot of people don't realize how much Medicaid actually impacts all of our lives. Medicaid covers a lot of different programs, including public health programs, including services in schools, including work-based programs to support disabled people in their workplace, case management services. So, you know, when I think about healthcare, I think about Medicaid because it covers so many services, particularly for the most vulnerable in our community. So rather than what this reconciliation bill just did, which was cut over, I think, $7 or $8 billion of Medicaid funding, that we need to actually boost Medicaid funding because dollar for dollar, it is actually one of the most financially responsible things that we are doing in society today, because we are addressing healthcare at its source. We're addressing health at its source by providing this general healthcare for a wide amount of people. So we saw during the ACA, the expansion of Medicaid actually reduced mortality rates across the country. And it also helped reduce maternal mortality rates as well. So expanding healthcare is one of the most basic things that we can do to help reduce it. And then, of course, getting federally stating that the decision on Buck v. Bell, which says that individuals with disabilities can be sterilized against their will, we need to get rid of that as well.
Still law of the land. Thanks, Mia. Tiffany, would you like to add anything?
I don't think there's anything I can add to what Mia just said. I agree with everything she said. And I think we need to, as a society, well, I would say, the Americans with Disability Act was established. We needed to push for that, right? That didn't happen easily. That was something we talked about, that it didn't happen just organically, as the representative was saying. So we've already seen the Section 504 has been attacked. We've talked about that. And the reason that the challenge was changed was because there was advocacy. There were letters sent. And so I don't really think, like I said, I have anything to add. I just second everything Mia just said.
Thank you, and I'm going to third it if that's possible. Before we end, I want to ask both of you, because I like to end with something positive. What gives you hope? And if you could leave our audience with one call to action, whether they are researchers, providers, policymakers, community members, what would that be? So Tiffany, why don't we start with you?
Sure. I would say one thing that gives me hope is events like this, to be very honest. Having this conversation publicly that people are attending, creating a climate where it's not taboo to have these conversations, but rather it's an open environment and something we should be talking about so that the advocacy continues. I'm really thrilled to see the number of folks that we have here today, to know that it's being live streamed and being attended virtually as well. And it also, the fact that these events, exist gives me reason to continue the work that I'm doing, which is about spreading information, and especially the confusion that exists out there around the medical system in general, but specifically around the news we're getting about abortion, things that we shouldn't be missing, that are easy to overlook. So I feel like we are making progress, and we can keep our chins up that way. I think a takeaway I might leave for the audience would be that representation, like we've talked about, is so very vital. We need to call for that. We need to push for that representation in all aspects of healthcare. And the more we can see people that represent ourselves, bringing in interpreters so there's communication access, accommodating patient needs, whatever they may be, I think that'll go a long way.
Thank you, Tiffany. Mia, what about you?
Oh, gosh. What gives me hope, I think, is seeing the progress that we have made, even though at the federal level, we've seen a lot of rollbacks. I think more and more people understand that disabled people exist and that our needs should be addressed. Like we at the Center for American Progress, we hosted a summit recently just on disability, reproductive healthcare, and equity, and had a bunch of different organizations from the disability community and the reproductive rights community come together and talk about sort of our agenda for the next 5 years. So being able to have something like that and have over 40 to 50 people come and attend, that's huge. We would never see that even 5 to 10 years ago. So being able to see the March of Progress, being able to see someone like Representative Ayanna Pressley talking about these issues, it's a huge win. So that keeps me hopeful. in terms of what folks can do. I'll try and keep this C3. But educate yourself on various policies that can impact your life, and talk to folks who can make decisions around that.
So talk to folks. Thank you. Thank you, Mia. Thank you, Tiffany. Really, thank you for sharing your insights. And we have a little bit of time for questions. So there are questions that have been coming in, and those who are here in person, I think there are QR codes in your chairs, so do whatever needs to be done to get the questions across. I'm going to start with, okay, this is a great segue to Mia, to what you just talked about, is how do you think we build bigger coalitions? How do we get traditional reproductive advocacy organizations to see our collective struggle and power? It's better, but still not great.
So I'll tell you what I've done, and then I will talk about how that's somewhat unfair to the community and how we can somewhat address those issues. So for me, it's all about being doggedly determined to get your voice heard. So for me, I do a lot of research. I look for the people who are in charge of whatever area that I want to get them to hear me about a specific issue, and then I send a lot of emails until they respond. So, you know, I think it's really learning who are the players in the work, learning about the issues, and then connecting with the people who are doing the work is really important when you're sort of delving into this type of work. I think that a lot of times it has become incumbent on the disability community to have to do that outreach, and that's where I'm saying it's a bit unfair because our issues are not very unique. They're just exaggerated, and that if you address our issues, you're addressing a lot of people's issues. We kind of call this in the disability community the curb cut effect, where you provide a service or you provide a policy that is intended for sort of some of the most marginalized communities, including the disability community, and it has a tendency to have sort of an echoing effect that improves the lives of everybody. One of the things we try to talk about when we talk about disability is you can become disabled at any time, and this isn't a threat. I'm not saying I'm going to make you disabled, but what it is talking about is that the disability community is so spread out in our communities today, and is actually increasing due to, one, aging, two, because of our crumbling healthcare infrastructure, and three, because of the mass pandemic that we are still somewhat in. All of those three factors has resulted in a significant increase in disability across the country and across the world. So these are issues that need to be addressed. And so talking to folks about that and encouraging them to reach out to the disability community is something that I try to do so that the next person after me doesn't have to fight so hard.
Great, thank you. Tiffany, we have a question for you. What do you think interpreters can do to improve care in reproductive healthcare settings for deaf patients?
That's a great question. I think educate themselves in the way that other people would need to educate themselves, and then be prepared for whatever situation you're going into. If you can, you know, if you are comfortable holding hands with the patient, if you can provide some sort of supportive words. I know there are boundary concerns. I know some situations it can be okay, depending on who you are and who you're working with, to be flexible about those boundaries and be a human. I would say that.
Thanks, Tiffany. We have another question. The health of women and girls is crucial in the reproductive justice field. However, how can we also ensure that reproductive justice work, policies, and conversations are inclusive of all genders? That is, anyone can have a uterus, not just women. Mia, do you want to start us off?
Yeah, we actually are about to release a piece in the next couple weeks on LGBTQ and disability, the cross-section between them, because we know that disabled people are actually more likely to identify as LGBTQ, particularly trans individuals. And one of the things that we were looking at, and some of the stats that we were looking at, showed that disabled, trans, and LGBTQ individuals actually faced a higher barrier to access to care than people who are just disabled or women. And so I think really understanding the particular unique circumstances that these individuals face, whether it is a provider who is culturally competent and working with these individuals and is respectful of these individuals, whether it's respectful of the individual's gender identity or respectful of the individual's way that they identify as disabled. All of these things are extremely important for people to realize, and I think it's also really important as researchers is that we need to have the data. We need to be researching these issues, specifically talking to these communities, getting as much data. Unfortunately, the federal government has recently restricted the types of data that we can get, including issues around LGBTQ status, and that is going to really hamper our ability to provide care, respectful care, competent care for these individuals. And so we as individuals within the general communities that do research need to spend extra care and attention to these communities to ensure that they have the resources and support that they need when they're receiving this care.
Thank you, Mia. There's a lot to do. Tiffany, we have a question for you. Are certain policies in place regarding interpreters in medical spaces? Or are interpreters more common in certain fields or in certain cities?
I think it's a good question about the field. I don't know that I can necessarily answer. I don't think I know where in the healthcare field you see more interpreters. I know regionally or in cities, with their large populations, it's strange to say, if there's large populations, maybe in New York City, for example, Rochester, New York, have a large populations of deaf people, and then consequently more large populations of interpreters.
Thanks, Tiffany. I'm going to end with one question that I'd love for both of you to answer from the audience is, what advice would you give to disabled and chronically ill people who are struggling with gaslighting and discrimination in healthcare settings when it comes to advocating for their needs? Tiffany, I'm wondering if you can start us off.
Wow. If you feel like the provider you're working with is not respectful, not listening, not hearing you, and doesn't care, then move on if you can. It is your right. Actually, first educate yourself, right? I know that people say that, and it can be a challenge. You need to arm yourself before you go into these appointments. That's a sad fact, but arm yourself with that information, and then follow your intuition. Listen to your gut. If something feels off, believe it is off, and then move on. I know sometimes it can be difficult to advocate for yourself on a repeated basis. This is an ongoing challenge, particularly for people who are pregnant. If you feel well and you have a positive outcome, that's not necessarily that it was a lack of a negative outcome. It's just that maybe you're too tired from the process, too exhausted mentally and spiritually to pursue a fight about something. So find people you know that will support you in that process. Make sure you have a team in place. That would be my advice.
Mia?
There's two issues. One, for people who have the resources, I highly suggest that you, as was previously said, to be an advocate for yourself. If something feels wrong, get a second opinion if you have the resources to do that. Unfortunately, I know a lot of disabled people who don't have the resources, whether it's because they don't take your insurance or you live in a rural location, etc. I think, try and build a support network of advocates that may be able to come to your appointment with you, that can help provide that extra sort of leverage in those conversations, because sometimes when you go by yourself, they don't believe you, or they think you're drug seeking, or blah, blah, blah. So try and have somebody that you trust go with you if you're not able or don't have the resources to be able to get a second opinion. I know that the disability community is a community that talks a lot to each other. We use each other as sort of our own phone books in the community. So I highly suggest, if you are not involved with the disability community and you have become newly disabled, to find that network within your own communities. Sometimes it's in the real life community, sometimes it's online, but find that support network, because they often can give you suggestions on great providers, good hospitals, and the resources that you might need throughout sort of your experiences with the healthcare system.
Thank you, Mia. Really, thank you, Tiffany and Mia, for really sharing your wisdom, your perspectives, and really everything that you're doing, your commitment to reproductive rights for disabled people. I also want to, again, thank the Museum of Science for creating this incredible space, but also for inviting us to have this conversation, because as Mia said, it's these, and Tiffany, is that it's these conversations that need to happen, because this advocacy cannot just be on the shoulders of disabled people. Everyone needs to be part of it. Everyone needs to understand the curb cut effect, because we are benefiting from the advocacy that a few people are engaging in. So let's all be part of this community, and let's make sure that disabled people's rights and needs are front and center in our fight for reproductive rights. Thank you, everyone.